I'm Ann O'Day from the University of Kansas Cancer Center. I'm a breast oncologist here, and I'm so honored today to have a very esteemed board of presenters for you all. I'm going to ask that they each just introduce themselves. I think maybe we'll start off with Dr. King.
My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Institute. And it's a pleasure to be here with you and with all of my colleagues today to discuss these cases.
I'm Chirag Shah. I'm the Director of Breast Radiation Oncology and Director of Clinical Research at the Cleveland Clinic. It's a pleasure to be with all of you this afternoon.
monarchE. I'm the Associate Director for Clinical Research at the Stanford Comprehensive Cancer Institute in Palo Alto, California. Thanks for inviting me to participate in today's tumor board.
Hi, I'm Maxine Jockelson, and I am the Director of Imaging at the Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am both a breast imager and a PET reader. And I'm really thrilled to be back doing this conference with you.
A young woman, 36 years old, that had a self-palpated left breast invasive lobular carcinoma, stage 3A, prognostic stage 1B, ER positive, PR positive, HER2 negative, status post neoadjuvant, dose dense, doxorubicin and cyclophosphamide, followed by paclitaxel. She underwent left modified radical mastectomy and axillary lymph node dissection with 3 out of 21 lymph nodes involved, with negative margins, complicated by long thoracic nerve palsy and left arm lymphedema. She, because of her current, symptoms from her treatment thus far, she's very apprehensive about additional treatment toxicities. And so the question being posed is the optimal adjuvant management. So at this point, her symptoms include wing scapula, pain in the scapular region, shoulder, left or chest wall lymphedema requiring, to the extent that it's required, purchase of new clothing. Outside of that, she has a good performance status. She had her initial preoperative breast imaging had shown a left upper outer quadrant spiculated mass measuring up to 4.8 centimeters. The preoperative breast MRI, 4.7 centimeters, abutting the pec major with a clear flat plane preserved without suspicious right-sided masses. And then she had surgery that demonstrated 2 foci of invasive lobular carcinoma, 4.6 centimeters and 1.2 centimeters, that were grade 2 with a closed posterior margin at 2 millimeters. Sentinel lymph node, 1 out of 1 was involved, followed by nodal dissection with 3 out of 21 lymph nodes involved. So a total of 4 out of 22 lymph nodes were involved. The final pathology, again, invasive lobular carcinoma, ER/PR positive, HER2 negative with a Ki-67 of 7%. Additionally, she had genomic testing with an Oncotype DX with a recurrent score of 21 and had a panel genetic testing, which was negative. Her surgery, again, included the curative intent left modified radical mastectomy and sentinel lymph node biopsy, followed by left axillary dissection. And our discussion today want to focus on sort of her adjuvant therapy. And I think first, if we could just have Dr. King kind of comment for us about this complication of the wing scapula and the nerve injury and how you would approach a patient that had such a experienced such toxicity.
Thank you. Yes, the wing scapula is the classic sign of a long thoracic nerve injury, which is certainly one of the comorbidities that can occur with a complete lymph node dissection. Thankfully, we don't see it too often, but certainly in patients that have extensive disease within the axilla, it can be more difficult to preserve the nerves throughout their course. There is no therapy to reverse the nerve injury. Physical therapy is usually an important part of patient's recovery from these injuries. She also has experienced lymphedema, of course, also a frequent complication of lymph node dissection. And so physical therapy for the lymphedema as well as the musculoskeletal symptoms from the nerve injury would be our first recommendations. If her pain is persistent, then she may need to see a pain specialist for perhaps regional node block interventions. And again, thankfully, these are not common, but when they are, they can be challenging, and hopefully she can pursue several different lines of intervention to alleviate some of her symptoms.
Okay, thank you for that insight. And then Dr. Pegram, how would you approach her adjuvant systemic therapy?
Well, my enthusiasm for consideration of any further chemotherapy is diminished by the fact that she had not only poor tolerability to her original chemotherapy, but also a poor response, as would be expected for a strongly steroid receptor positive lobular breast cancer. So I would say that the overarching concept of adjuvant endocrine therapy would be the prime systemic adjuvant therapy that one would recommend. That said, one wonders in a case like this, which is clearly a high risk ER positive presentation, whether addition of another agent to her endocrine therapy, for example, a CDK4/6 inhibitor, might also add some benefit. Data have been presented from the monarchE clinical trial, which was an adjuvant abemaciclib clinical trial for high risk steroid receptor positive patients. And this patient fits into that category clinically. And so I would suggest that that might also be a treatment option. I have been able to get adjuvant abemaciclib covered by patients' insurance, at least in our region, for high risk ER positive early stage breast cancer. And so that's where I'd be going, in contrast to consideration of any post-op chemo, given her poor response, poor tolerability, and lack of expected response from lobular histology. I think endocrine therapy, particularly with a CDK4/6 inhibitor combination, would be something I would strongly consider.
And would you have a discussion with her about ovarian function suppression?
Absolutely, no question about it. Long term, given her high risk bulk disease, residual disease following neoadjuvant therapy, AI with ovarian function suppression as the backbone endocrine base with the CDK4/6 inhibitor would also be a worthy goal. Sometimes young patients can't tolerate that regimen very well, so but it is worth a try. And you can start out simply with the monthly dosing schedule of the LHRH agonist, and then graduate to the depot formulations with longer injection intervals out to 3 months if it's tolerated. And if it's not tolerated, you could always switch back to tamoxifen.
Thank you for that. And Dr. Shaw, any comments about how you would approach her adjuvant radiation therapy?
Sure. So obviously the patient unfortunately has had some side effects of therapy already and hasn't tolerated treatment well. The fact that she has this many nodes post neoadjuvant, from a clinical standpoint, there's no equivocation that we would recommend radiation. But in this patient, it would require a nuanced discussion about the pros and cons, namely the significant risk of local regional recurrence, which if it happened could significantly exacerbate her symptoms even more than the toxicities of radiation therapy. We do know that radiation in this situation is going to further likely exacerbate her lymphedema. So physical therapy, compression garments are going to be important. Her radiation planning may be impacted by her wing scapula. So making sure she's comfortable during radiation planning and for treatments is going to be essential to help her complete her therapy and with compliance. But overall, I would recommend it, and then slowly counsel her on the side effects and then potential ways to mitigate those toxicities.
Okay, perfect. So in summary, in terms of management of her pain and her nerve injury, physical therapy and pain management, and then optimizing her adjuvant endocrine therapy with ovarian function suppression and aromatase inhibitor with a CDK4/6 inhibitor, if that could be obtained as an initial strategy. If that wasn't well tolerated, potentially transition to tamoxifen. And then, of course, optimizing her adjuvant radiation therapy as well.